Welcome to the Understanding Healthcare podcast. I'm your host, Zach Cantor. Today, I have with me Varun Krishnamurthy, who's the co-founder and CEO of Assured, which is a provider credentialing and enrollment platform. Assured helps healthcare organizations onboard clinicians, manage provider data, and scale in-network across states and payers. And we're going to talk about what all that means, what exactly credentialing enrollment means, and how it plays into the rest of the transaction flow that comes with billing. So, Varun, welcome to the show.
Hey, Zach, thanks for having me. It's a pleasure to be here.
Glad to have you. Well, let's kick things right off. I'd love to just understand before we get into all the things that Assured does. I'd love to understand what you were working on before Assured and how you came across this problem, because it's not a business that everybody would intuitively start.
For sure. No, I love to joke that, ever since I was a kid, I was really passionate about credentialing, but, that wouldn't be the truth. Yeah, as you kind of alluded to, we didn't really start out trying to fix credentialing and payer enrollment and things like that. Our journey really kind of started at our last company. And when I say our, it's really my co-founder, Rahul, and I. We actually built a virtual sleep clinic called Dawn Health prior to Assured. And we were trying to make access to quality behavioral health care easier and more affordable for the tons of people around the country that struggle with, sort of really debilitating sleep conditions like insomnia, and are oftentimes very much underserved when it comes to treatment. And so, as we built Dawn Health, we were really hiring providers across many different states. And, we really tracked one metric obsessively, especially again, given our value prop, which was let's make this care accessible to tons of people who can't otherwise access it. And let's make it affordable through insurance as well, which was how long does it take from hiring a provider to them getting to see their first patient, covered by insurance. Um, and ultimately, this metric was, what determined, how much we could grow as an organization, but also how widespread our impact could be.
And what's a bad number and a good number there? Can you give us a sense
Yeah.
of what someone might expect?
Yeah, and so I actually will say, like, the bad number is ultimately like the status quo. It's what we deal with today, which is, many times anywhere from 2 to 6 months, oftentimes, depending on sort of what type of care you're delivering, what region you're delivering it in, and what health plans you need to work with, right? What sort of insurances you need to accept in order to treat as many patients as possible. And so it's a very long process. And, kind of interestingly enough, like I came from tech, my co-founder did as well. We really assumed it would be a very short and simple process. When I joined my first company that I worked for, a company called Yahoo, you know, onboarding took a couple days, right? And so that was really our expectation when we thought of, okay, when we hire our next provider, whether they're a doctor, a nurse, a licensed clinical social worker, um, we kind of assumed the same. But the reality was very different, and it ended up taking many, many months.
And
And
so what this looks like is, it's not like I'm a fresh grad. I've worked at other sleep clinics before. I've worked at other sleep clinics that take Blue Cross Blue Shield, Anthem Blue Cross Blue Shield New York, and I sign up to work with Dawn Health, and I'm facing a potential 6 month waiting period before I can start accepting my first patient, despite I'm seeing patients somewhere else. I'm accepting Blue Cross Blue Shield somewhere else. Is that more or less the story?
absolutely, you hit the nail on the head. These are providers that have tons of experience, have dealt with massive patient panels, worked at many different organizations. But no matter all of that, the next organization they join, they have to go through these processes over again, and end up having to wait, very long periods of time.
And did you solve this at Dawn, or did this was a never ending pain? Like, I'm always curious with these businesses. Sometimes you hear one of two stories. One story that you hear when someone's comes across a problem in their first startup is they say, "We solved this at the first startup, and then we said, quote, all we need to do is extend the problem a little bit further." Steady, I would say, fits into that category. I previously started a brand of auto parts. In building that business, I had a homegrown EDI system built for my auto parts business. And I said, I think it cost me $50,000, which was a lot of money for a small business to build this custom platform. And when I started study, I said, it's going to cost at least 10 times as much if we're going to solve this problem for everybody everywhere in all industries. And so I said, I'm going to raise $500,000, but just to be safe, I'm going to raise $1 million so that I have like a 2x margin of safety here. And that should do the trick. And, fast forward, studies raised $142 million. So I was off by, two orders of magnitude and more. Um, I'd say the second kind of class of company is that you come across this big problem, you don't solve it at all at the first company, and you say, the bigger thing we're going to work on is solving this problem the next time. Curious, along the spectrum, what lands there.
Yeah. No, well, first off, congratulations with, everything that, sort of Steady has been able to achieve so far. I think we fit really very much into the latter, right? In terms of, Dawn Health allowed us to see the problem, but we didn't sort of leave Dawn Health having solved it, right? Assured is ultimately our attempt, right, to solve this problem. Um, what building Dawn Health allowed us to see was really the reality again, kind of facing that pain point firsthand, feeling that pain as a customer and as an organization that needed to hire providers, couldn't do it fast enough. And so we were really able to kind of peel back the onion a bit, right? And see sort of how do vendors operate in the space? What is the reality? What are our peers in the space, right? What are other clinics, other health systems, other provider organizations around the country facing as well? Um, and so, what that really was ultimately was, huge teams doing manual work, right, across data collection, data cleaning, sending emails, filling out forms, making phone calls over and over again, and making lots of mistakes along the way, right? What we saw on the ground was lots of these teams being overburdened, and actually a lot of that leading to massive delays.
Super interesting. Well, maybe, to ground this in an actual example, I know that we've talked a little bit about Dawn Health, but if we think about, let's say I am, a freshly minted doctor here, and I'm ready to start, I'm going to go start my own private practice. I've just finished residency. What do I need to do before I can start seeing patients and billing insurance? Can you walk us through what the difference between credentialing and enrollment is, and what other pieces that we might be missing here?
Yeah, absolutely. So as you kind of mentioned, imagine you're a doctor, you've just finished residency, you've been training for, let's say 12 plus years. You're in a little bit of debt, unfortunately, and you're ready to start your practice. You've seen tons of patients over time, you're well trained, but then you find out you can't actually see patients just yet. There's a lot of steps you have to follow before you can actually work. And what those things look like is you ultimately have to, submit your full education history, right? Everything you've done. You have to provide all of your licensure, any board certifications you have, tons of professional references. At that time, maybe you had employment or maybe you didn't. But if you had any gaps, you have to be able to explain that. If you have any malpractice lawsuits against you, you have to have an explanation for all of that. You have to upload your data into multiple systems. And then oftentimes, you have to wait weeks and oftentimes months for folks to get back to you to review that information, and then ultimately get you approved so you can see patients.
And
And
this is on a per effectively per payer basis, and so I forget what this thing is called. Remember, there was the applying to colleges, the Common App, was that what it was called? Where okay, they've standardized it, but then like there's also an addendum to the Common App. Everybody, they want you to do the Common App plus something else. Is there an equivalent in the enrollment credentialing world where you're filling out one thing that's federating out to a bunch of payers? I know that that's what you're building with Assured, but is there some framework under the hood, or is it truly bespoke for each payer?
it's a little bit of both, actually, right? So there are kind of centralized, let's say you can call it a digital resume, or like you put a common app, as we like to call it for doctors. That's called CAQH, actually, which is the Council for Affordable and Quality Healthcare. Um, However, it's not a silver bullet, right? Every health plan, kind of very similar to colleges, right, if we use that analogy, right, has its own supplemental process you can kind of think of, right? So they have their own portals, their own applications that you end up having to fill out yourself. And there are ultimately health plans that don't even use, right, that common app. They don't even look at it. Medicare, for example, has its own portal, its own sort of provider data system called PICOS. And so ultimately, it's very bespoke, right? Across, again, specialties, oftentimes across states, across health plans. And so there's tons of variability and it's very hard to track for providers. And that's why ultimately, companies like us need to exist because sort of that knowledge has to live somewhere because otherwise sort of it becomes very unwieldy and hard to navigate.
There's this great blog post, which we'll put in the show notes, called Reality. It has a surprising amount of detail by a guy named John Salvatierre. Have you ever come across it?
No, but I'd love to hear a little bit more
Oh,
about it.
it's like a big part of the study canon. We talk about it all the time. Basically, the gist of the post, I spent a long time since I've read it, but the gist of the post is that so you've walked up and down stairs many times. And so if you end up having to, you're tasked with building a staircase at some point, you're like, oh, how hard could this be? Yeah, I kind of get it. It's got the boards on the sides, and it's got the actual floorboards, and okay, it's got to be at an angle and stuff. But you know, everything from actually cutting the lumber at the right angles, a consistent angle on both sides, to figuring out like how deep should the step be. Of course, with ChatGPT is a lot easier now, but it's still, it can't do the cutting for you. And there's a similar thing. I don't forget if it's talked about in this post of where they've done exercises where they've asked people to draw a bicycle, and most people have ridden a bicycle, most people have seen a bicycle all the time, and most people can't draw anything that remotely resembles a machine that could function. And it says reality has a surprising amount of detail. It's one of these things that we see in our world. I say every time you pick up a rock in the healthcare RCM world, you find three more rocks underneath it. And I imagine it's probably similar for your business. It's fractal complexity all the way down, with each one of these processes.
Absolutely, absolutely, and I think, if I were to sort of paint the picture of what it looks like, for a day in the life, let's say a credentialing team member, right, at, let's say, a large health system or a clinic, no matter the size, it's really sort of maintaining, like, tons and tons of, like, tribal knowledge, right, of, you know, like you kind of alluded to, right? All this variation and edge cases and things are always changing. And so you think you have something solved, right? And then all of a sudden the rules change and you have to adapt to that very quickly. Um, there's lots of that. There are, as we kind of talked about, there's specific rules, across different health plans and different states that folks always need to track and they're changing just rapidly, right? We see that and it happens oftentimes without a rhyme or reason, and you have to adapt very quickly and make sure that, you can still stay on track. And so, I really think that folks and organizations in this space, people that work in this space, they to this point they've had to do this very manually. There hasn't been sort of a source of truth or rules engine, right? That one could track and use to actually help drive, these processes forward. Um, a lot of what, we think about when trying to build a shirt is actually build that source of truth, right? And we think a lot about it a lot in terms of like TurboTax, right? I don't know what I would have done, in terms of filing taxes, whether it's at the state level, at the national level, especially when moving, I would not be able to know, right? What the regulations were and what information I had to share. TurboTax makes that so easy, right? It tracks all of that for me and just sort of asks me what the information that it needs in order to sort of make sure, I file my taxes correctly. That is ultimately what we're building with the shirt, right? Across credentialing and health plan enrollment and various other problems in the healthcare back office is let's build this sort of operating system or orchestration system that can actually run these processes on autopilot and sort of maintain all these rules for you so you don't have to.
It's interesting. We use a tool called Mosey, Mosey, for state compliance, just at a corporate level. So we have people in a couple dozen states, and so there's sales tax nexus, there's other type of nexus that you have where you have to register to do business in the state, and different states have different requirements, and so they handle this. And I think a lot of the things they handle themselves, they file electronically, and then occasionally you'll get a request that you need a wet ink signature on something. And I imagine it's a similar. I've never seen your tool, but I imagine it works in a similar way. Can you talk to us a bit about the other pieces aside from the credentialing enrollment that are going to be required, and whether this is something that you do or don't do? So contracting being one example of that, I'm assuming that people need to do. What are the other pieces that are missing from the picture?
Yeah, there's actually quite a few. Like you mentioned, contracting being, one where, you can get a network, right? You can do all the steps of credentialing and health plan enrollment. Um, and then you may get rates that you don't like, right? And you want to negotiate that with the health plan. A lot of organizations end up doing that. And so that is one process that very much happens sort of post all of the credentialing and health plan enrollment that really looms large for a lot of organizations. There are a number of other things I would say kind of very much in, let's say, this bucket of recurring things you have to do, right? Month to month, year to year. For example, there's maintaining your provider data profiles, right? There are, we talked about CAQH, we talked about PICOs, we talked about, actually when we as patients, want to find a doctor, we're going to go to our health plan directory, right? And find out who's a network for me, right? That I can go see as soon as possible. Um, that data is actually credentialing and contracting data, right? That goes in there in terms of what's the phone number they can be reached at, what hours are they available, where can I find them, and what health plans again, or what sub plans, right? Are they in network with, whether it's like an HMO, a PPO, et cetera. Um, and so that actually requires a lot of upkeep, right? That data can become stale. That data can actually be wrong from the get go. And so it actually requires monitoring. And so every month, for example, organizations have to track these things. Let's just say, a provider gets married, changes their last name, or they change locations, right? If that data is not updated with the health plan or submitted to the health plan, claims can get rejected, directory information can again be out of date, and patients won't find you. And so that's actually a massive, massive problem for organizations. And so, these are other ways we help organizations beyond that one time, right? Of, what, we're going to help you get credentialed, we're going to help you get a network, but we're not just going to stop there. We're actually going to help you maintain that status over time and make sure, again, you can keep seeing as many patients as possible, and, make sure you get paid for the care you deliver.
Can you walk us through the nuts and bolts of how some of that works? So, I'm curious, is it based off of self-reported information from the provider, or are you doing things like checking Secretary of State filings and things like that to see if somebody updated their address, or checking, some of the KYC data that you can check to see if somebody's changed their last name?
Yeah, it's really a mixture of both. Part of it is because, providers are so busy, they're seeing patients. That's really what they want to do, deliver quality care and help people. And oftentimes, naturally as humans, we forget, right, to share an update when it comes to, hey, again, my name changed, or I moved locations, right? Or something with my license is now different. So as a result, we end up having to check, various sort of third party sources, like you alluded to. I think one very common one is actually various state license boards, right? They are generally the source of truth for this when it comes to, has any sort of information like this changed related to a provider. And then beyond that, there's again, like kind of where are they still working, right? So you can check sort of NPES, which is the national directory of sort of NPIs, right, across the country. And so we have to end up stitching together, information from so many different sources, which includes the provider, includes the organization they work for, and all these sort of different sources of truth on the internet to find out what is actually true, right? And it's not always an easy problem, right? Where you won't always have 100% certainty, but kind of bringing that all together allows you to have the highest level of confidence, right? That you are maintaining accurate data, and then kind of sharing that with the relevant parties.
Is this kind of like, it sounds like a huge amount of work when you go and you see a doctor's office, and they accept 3 different types of insurance, and if you're wondering why don't they accept 15 more, how much of it do you think is this problem versus, versus contracting and preferred rates and things like that? Like, it's a tough question to answer, but do you have a sense of how big of a bottleneck this is?
Yeah, I think it really depends also on the size of the organization. What we've seen is a lot of clinics around the country, a lot of the smaller practices especially, it's actually very much of a administrative issue for them, right? In terms of I have to track all these things. I have to find out ways to apply to these, health plans to get in network. I have to, outside of seeing patients, right? I have to get smart on these processes, and ultimately that's too much for me, right? In many different cases. And so I don't end up getting a network. And we actually saw that quite a bit at Dawn Health. When we were working with lots of providers, um, they hadn't been in network with health plans before. And the reason was not because they didn't want to be, right? Because being in network actually allows you to see way more patients. The reason was that it was too difficult, and sort of amorphous of a process, right? For providers to follow. And so we see that being a massive issue. On the flip side, I think large organizations, they oftentimes can actually terminate contracts with health plans if they're not getting preferred rates. Actually, I went to the optometrist the other day, and they told me they're no longer sort of in network with VSP, which is the largest, right, sort of eye care plan. And so I've seen that, quite a bit, whether it's at urgent care, at various hospitals, et cetera, where they're no longer in network with one of the massive plans in that given state. And that often happens due to simple disagreements, over rates. I mean, it has a massive impact on patients.
Yeah. Well, I mean, you see this on TV. It's, such and such has dropped ESPN or whatever, and because these contract negotiations. Yeah. Well, we've talked a lot about in network. Now we also see there's some interesting things when it comes to provider enrollment versus transaction enrollment, and Steady has to handle something called transaction enrollment. And transaction enrollment is different from provider enrollment. It's for the uh, configuration process with payers for certain transactions like the ERA, the electronic remittance advice. It seems that people are often confused about the difference between credentialing, provider enrollment or payer enrollment, transaction enrollment. Can you walk us through what the differences are between those things? Which of these things could be done, as a standalone item? Which ones are dependent on others?
Yeah. It's a great question, because all of these steps have to happen, right, for a provider to be able to successfully be in network and get paid for the care that they deliver to their patients. I'd say you can think of it like this, right? Credentialing is like the background check, right? It proves that you're qualified ultimately to see patients, and that you're a good actor, right? Payer enrollment is really the process of getting you added to, let's say, Aetna's or Cigna's or United Healthcare's roster, where they recognize you as a provider that is in their network and able to treat patients that have that insurance. Um, and as you kind of pointed out with the transaction enrollment, that is to make sure that you can, really kind of downstream of all that, actually submit claims successfully, right? Um, as you pointed out, I think folks get those terms confused all the time, uh, across, credentialing, payer enrollment, transaction enrollment. And I think it's for ultimately like two big reasons. Number one, uh, there's a lot of overlapping information that has to be shared for each of these processes, right? We can think of when we talk about licensure, right, or education, or NPIs, right? A provider ends up having to share that for each and every one of these processes, right? And so there's tons of overlapping paperwork there, that I think, sort of really lends itself to confusing these processes. I think the second thing is actually kind of inconsistent language that we as a healthcare system oftentimes use, for these processes. One thing I can, as an example, right, some health plans refer to, the process of getting a network as, hey, join the network, right, and enroll with us. Others call that a credentialing application, get credentialed with us, right? All of a sudden that gives really a strong opportunity for folks to mix credentialing and enrollment, right? And we see that happen all the time.
And are these actually, in many cases, discrete processes where, you can go through a credentialing flow with United Healthcare, and that would do nothing for you, right? That just is the only purpose of that is to go through enrollment.
Yeah, absolutely. I think what we've seen is actually in many cases, health plans can actually have what's called like closed panels, which means they're not actually accepting of a specific provider into their network. And that provider could be perfectly credentialed, right? Have no red flags in their background. Um, they're very much qualified to see patients. But the health plan can just say, hey, we already have enough of this type of provider. We're actually not going to add you to our roster, right? And add you in network. And so, the sort of the front end, right, for providers and provider organizations is really the same. But the processes end up being, to your point, pretty discrete, right? Um, and so, yeah, you can get successfully credentialed, but not actually enrolled, if that makes sense. And the order in which these things happen also differs by health plans. Some will do the enrollment first and then later tell you, oh, oops, you actually didn't get credentialed, or vice versa, or they can happen in parallel. And so it leads itself to a lot of kind of, I'd say, kind of confusion over when will I actually be ready to bill? Right? I think that's the question every provider asks, and oftentimes, again, that answer differs across health plans.
Curious from a business model standpoint, if you can share, people take different approaches to this stuff. Sometimes, the approach is, hey, if you're a solo practitioner getting started for the first time and you want to get set up for one payer, we're happy to have you as a customer. But and other people are going to price in such a way that that wouldn't be realistic. Do you all have a philosophy on this of the sort of, aside from this ideal customer size, the actual customer size that you're willing to accept?
Yeah, I'd say, one thing I'd say to start off is, I think we can drive the greatest value, for organizations that have to do this a ton, right, at high volumes. With that said, our vision, our dream ultimately is to, if we as we successfully build, the turbo tax as we described, right, for this process, anyone should be able to use that, right? No matter whether it's an individual provider or a health system with thousands, right? And so our vision, our dream is to actually serve sort of everyone in healthcare who needs to navigate these processes. With that said, kind of in the process of getting there, we definitely kind of have started with some of the larger organizations, right? Where we can drive as much value as possible, and really refine, our product and our technology before sort of exposing it, to everyone in the country.
Yeah, I'm fascinated by these
Yeah.
decisions because, at one level you have Stripe, who they were and are willing to onboard anyone and everyone, and we fit into that category. So we'll onboard anybody, no matter how small. If it's a solo provider who wants to sign up and do basic submissions through our user interface only, or if it's a super high volume person, and then you see lots and lots of, for example, the AI uh, sales development platforms where it's 100 seats minimum, something like that, and both of them work, and both of them are successful models. It's always
Yeah.
interesting to see,
Yeah,
what makes
absolutely.
sense.
And I think just to add to your point, I think it's a testament, right, to companies like Steady and Stripe, where you've been able to build ultimately what is largely a self-serve flow, right? I think we think that one of the reasons this has not been successfully done, in the credentialing and health plan enrollments and sort of overall sort of provider network management space is that when people are in the loop for every single process and doing all the heavy lifting, it becomes very hard to scale that, right, over time. And businesses have struggled to do that. As a result, you know, ultimately, it doesn't make sense for them from a unit economics perspective, right, to serve the individual when they have to hire people to be dedicated to that process, right? Our vision is to have technology drive all of that, right? And as we know, that can scale completely differently. And so that is a change we're really trying to make in this space. And, you know, if we're able to achieve that, right, and really deliver on that, we should be able to do it for sort of, again, organizations of any size, right? And even the individual provider.
Yeah, I think it's basically like, can you drive how quickly can you drive non-determinism out of the system? So if you're starting out with a non-deterministic process, it's just not practical to onboard anyone and everyone because you're having to take those human in the loop processes and turn them into things that are deterministic. We're fortunate in that because of the administrative simplification rules that came as a result of HIPAA, Steady is effectively a zero config system. So you set up Steady. It's not like you have to go in and get your account configured just right in order to use it. It's, yeah, sure, there's payer specific nuances in claims, but like generally you kind of just sign up and use it in a similar way to, Stripe has grown a lot and has a lot of configuration. But if you just want to accept Visa, MasterCard, Discover, American Express, on your website, it's pretty simple to get it set up.
Yeah, absolutely. I think really that level of, again, rules engine and orchestration is what is missing, in our space, and really something that's very core to our business ultimately, right? For us to, again, build technology that can, like you said, turn what has been, largely non-deterministic processes into something very deterministic, right? Um, and if I were to, really describe a day in the life ultimately, again, right, of a credentialing analyst and what they're doing, I think it will really speak to the level of sort of complexity, right, that they deal with, and why it's been hard to maintain all these rules. Um, First of all, organizations, of different sizes have their own sets of rules in terms of what is all the information, that I'm going to collect, right? And so if I'm that analyst, or if I'm that worker, right? First off, I have to go to a provider. I have to collect, again, all their work history, their licensure. I have to collect it in a very specific format. I have to collect maybe additional information as well. Um, and then what may happen is that data may not be accurate, right, or complete. And so I have to spend a lot of time sort of going back and forth and cleaning that up. Then what I have to do is I have to go out and verify that. And that verification, to your point about, being deterministic or programmatic, is anything but, right? I have to go to many different portals. They require all the logins, the two-factor, right? I have to go pull a document oftentimes, read that document and see, okay, does this provider actually have the license they say they do? Do they have the board certification they say they do? Are they educated, where they said they went to school? Um, does their license have any actions against it? Right? Or is it suspended, et cetera, right? And so much time is spent doing that. And then once all of that is done, kind of like we've talked about, right? Then that is when, you actually have to enroll them with Aetna, Cigna, Medicare, Blue Cross, Blue Shield. Um, and as we talked about, those rule sets are very, very different. For example, Blue Cross Blue Shield actually, in every single state, there's a completely different process, right? Medicare has its own sort of its own universe of rules, um, and so maintaining all of that and sort of learning those specific rules is just very, very difficult, right? And so we've seen sort of how naturally, we're all human, how an ops analyst can kind of struggle to keep that all in their minds. But it's also been hard to actually maintain a list of all of that, right? Like how have organizations have struggled to keep track of all the sort of variability and edge cases that come out of this, right? And the special rules. And so it's a very interesting problem, right? Ultimately, but again, we believe that machines are much better suited to do this. I think we as humans are, what we're great at is strategic, creative, interpersonal interaction, kind of orchestrating and managing systems. I think what we're not great at is, parsing data points, filling form fields repeatedly, and keeping track of a massive corpus of rules, right? And trying to update our priors based on, new information we learn. Um, I think technology is much better at that, right? And so ultimately that is, what we need to build in this space, to really sort of overcome a lot of the roadblocks that exist, and again, achieve that goal of how do we get a doctor, in network as soon as possible.
Super interesting. Yeah, I'm curious, like, how do you handle, um, you talked about working with large organizations. When a large organization onboards with you, how do you handle knowing where they're already credentialed and enrolled? Is that something that you can just detect? Is that something that's self-reported? Is that, how does that fit into the picture?
Yeah, it's funny enough that that sounds like a trivial problem, but it's actually a massive
It
one.
doesn't sound like a trivial problem. Like where, yeah, where it's we see this with ERA enrollment of yeah, it's very complicated.
I wish it was trivial, I'll put it that way, right? But unfortunately, what that requires is actually kind of a combination of things, right? We have to take the self-reported information from let's say the organization themselves. We're going to check directories. You know, we have to check with the health plan themselves. Oftentimes that actually requires tons of like emails and phone calls, right? Staying on hold, navigating IVRs just to get information on is such and such provider in network, right? Are they affiliated with the right location? Right? Are they in network with all of the subplans, right, of a health plan or only some of them, right? One example would be you can be a network for all of Aetna's commercial plans, but are you a network for their Medicare Advantage plans, right? That nuance really, really matters, right, in terms of which patients you can actually see. Um, and ultimately, sort of that data is sort of hidden away in various systems. And oftentimes, the only front door to that, again, is making that phone call or sending that email and getting confirmation that way. Uh, and then again, verifying that against directories, right? And sort of that publicly available information as well. So,
How often are you coming across scenarios where, somebody doesn't tell you that they're enrolled with Blue Cross Blue Shield Rhode Island, and you go through the whole credentialing enrollment process only to find out, hey, you're already enrolled?
yeah, we see that all the time, actually. And part of the reason for that is, you know, if you put yourself in the shoes of a provider, right? Let's say working in Rhode Island, um, they worked at a clinic prior and got in network through that clinic with Blue Cross Blue Shield in Rhode Island. Now they changed roles, right, and went to a health system in Rhode Island. They have to go through that full re-enrollment process with Blue Cross Blue Shield, excuse me, in Rhode Island again, right? And what that means is like are they in network? When you ask them, "Are you in network?" Well, technically, you were, right, with the clinic you were just at, but you're not when it comes to the new health system you're at,
And to
right?
be kind of precise here, they're
Mm.
credentialed, but they're not enrolled because the credentialing belongs to the provider. The enrollment belongs to the TIN.
Exactly,
Okay.
right? And
Yeah.
so they're in the system somewhere, right, with Blue Cross Blue Shield in Rhode Island, but they need to be affiliated with the right location, in order and right organization in order to bill successfully. And so things like that lead to a lot of confusion, right? Both for the provider, but actually for, let's say, the organization that's even handling or the worker, right, that's handling this process, because it can actually affect how you get that provider enrolled with Blue Cross Blue Shield in Rhode Island. And what I mean by that is, do I submit, a full application, almost like they're a brand new provider, right, to join that network? Or do I have to submit what's called a demographic update, which is, as you pointed out, they're already credentialed, they're already in your system, but we need to change sort of the organization that they're affiliated with. And oftentimes, if you do the wrong thing, it'll lead to massive delays, which is very, very costly, uh, both to the provider and to the organization they're joining.
As we're talking about all this, um, curious, is there an effort? Has there ever been an effort to standardize this stuff? There's quite standardized processes for ERA enrollment. It's still very complicated, but there's a standardized form and some other stuff. Uh, is there anything like that that's been discussed or is being discussed?
So I think there have been attempts, right? I think CAQH was sort of one attempt to do that, and I think they got decently far. And what I mean by that was allowing sort of one standardized format, right, or data structure where providers can submit their data once and sort of use it everywhere, right? Unfortunately, kind of that has not sort of reached sort of the level of maturity and sort of become widespread, and that's because each health plan ultimately has decided to kind of follow their own process, right? And so we've seen a lot of like kind of structural issues there when it comes to, following one sort of unified process. Um, that's something I would love to see, right? What I would love to see in this space is providers can actually maintain their own sort of, you can think of it almost like a credentials wallet, right, of information. And they can decide to share that, and it can just be sort of one data format that, whether it's Aetna, whether it's Medicare, whether it's Cigna, they all use. And, that would bring sort of massive, massive value, to the healthcare system. And really streamline a lot of processes. But we've seen that be a major issue. So right now, these processes are so fragmented, right? And I think various organizations have attempted to again do this, but what that's led to at this point is even more fragmentation.
Yeah. Is we're kind of stealing ahead from our final question here, but we're coming into the last couple of minutes anyways. Is that your answer for if you could change one single thing about revenue cycle management, or credentialing, and enrollment that doesn't require a fundamental reworking of the whole system? Uh, what would you change?
Yeah, absolutely. I'd say, you know, I think the healthcare system right now, we ask for the same information in hundreds of different ways. I think we need to remove that, right? Um, it leads to massive redundancy. Leads to tons of errors, and it leads to wasted time. I think if we simply had a shared, standardized, again, sort of provider profile format and one clean way that everyone can submit information and others could accept it, we could eliminate a massive amount of friction. And ultimately, that shouldn't require regulation in my mind.
Yeah, it's interesting. It's not too dissimilar from the problem of just kind of identity in general. So when you look at this comes up every number of years, people propose a national ID for people, and there's data privacy questions and a lot of things that people don't love about it, and the the fact that ID is fragmented across Social Security and your state driver's license and your passport and the what's on file with the IRS, like, theoretically makes it more difficult to for the surveillance and things like that. No, I think you know, I think that if the government wants to know everything about Varun or Zach, you know, they can assemble all that information using Palantir pretty easily. But I think probably broad scale, full analytics is across everybody is more complicated because the um, fragmentation of identity. But it sounds like some sort of a national provider directory that could be used as, maybe even used as an SSO, and SAM will log in for different things, could be hugely beneficial. Is that the sort of thing that you have in mind?
Absolutely. I think something of that nature, which could also track, I think one of the big problems again is knowing for, provider John Doe, right, who maybe sees patients across many different states, right, has worked, like we discussed, across multiple different healthcare organizations. What are all the plans they're in network with? What is, sort of their essential data in terms of their licensure, where they went to school? Can we have that all in one place, right? Can we know if I just make one query or ask one question, John Doe is in network with all these plans, all these sub plans, effective as of this point in time in all of these states. That would solve massive problems again, I think, for the industry.
Yeah. I mean, I'm just thinking through all the complexity. Part of the problem is that even the names of the plans are not standardized, and there's no standardized ID. So our ID, Steady's ID for a payer is going to be different from your ID. So we would need a national payer ID. I mean, a national payer ID would be so high on my list of things that we wish you could wave a magic wand on. Have you ever seen I remember years ago, reading about the Estonian, digital identity system where they implemented this digital passport basically, was the common thing between their taxes and everything else. I'll see if I can dig the article up and send it to you and put it in the show notes, because it's that sort of concept that I think would be such a huge unlock, where you've got a digital identity for a provider, and a practice, and it can be used everywhere.
Absolutely. I think, actually India has created sort of a primary or unified, personal identity system called Aadhaar, which kind of, as you alluded to, is a unique ID, right, given to sort of each individual in the country. And it acts as like a foundational ID for, government services, for banking, et cetera, right? And I think it's brought actually massive efficiencies, right, to the country, and I think is a good sort of symbol, right? Of okay, if we took this approach, to many other systems as we're discussing, like it can reduce a lot of the friction, and they've been able to do it at the scale of a billion plus people, right?
And we kinda have it already with NPES, with the NPI registry. You've got unique
Yeah.
IDs, you kinda just need to just need to hang off a bunch of
Yeah.
other information on top of that.
Yep.
Well, thanks so much for coming on the show. This was great. Wanted to come in and learn everything we could about credentialing and enrollment, and sounds like you all are doing God's work in making this easier. So thanks so much for coming on. It was great to have you.
Thanks for having me, Zach. This was super fun.